Welcome, everybody, to another episode of Probing the Literature. This is the National Ultrasound Journal Club, supported by the American College of Emergency Physicians, Emergency Ultrasound Section, and the Society of Academic or for Academic Emergency Medicine's Academy of Emergency Ultrasound. And we've got two great papers that are going to be presented today, both of which were nominated for a SAMMy's Award, which is Best of the Best papers of 2025. So our first author is going to be Sydney Todorovich, who's here going to be presenting her paper. And so Sydney has an academic appointment with in Western Canada, and she's getting ready to transition to Elliott Hospital in New Hampshire. And she's Canadian trained and in EM and POCUS, and is recently moving to Massachusetts and starting a new career in New England. So welcome to Probing the Literature, and I'll let you go ahead and start sharing. And I think her paper is going to lead to a lot of good discussion.
Okay, thank you for that introduction. Let's make sure okay, perfect. Sometimes a little bit technologically challenged here, but yeah, thanks for coming. Happy to chat about the paper. I guess the title of it is the 3M Defib-Pads as a reusable alternative to commercial ultrasound gel in resource-limited settings. Maybe it will work. There we go. Okay. Don't have any disclosures. Nothing to talk about there, unfortunately. So I was asked to talk a little bit about where I got the idea for the paper, and it really started. I was in residency doing my POCUS fellowship, and then also doing wilderness medicine fellowship, just kind of longitudinally. Obviously wanted to be able to use both of them together. I had a butterfly that I would take with me to the wilderness medicine events that I would volunteer at. And kind of came to realize that the gel was just annoying to use. It was really kind of cumbersome. It was as big as the butterfly itself. And obviously, if you ran out of it, then you didn't really have much else. And so it kind of got me thinking, what are some other alternatives that I could use as typical in emergency medicine, and also even more so in wilderness medicine, just trying to kind of MacGyver and use things that you have at your disposal. So I went to the literature. There was a handful of papers that were already published on other gel alternatives, mostly like making your own gel or using things like hand sanitizer or whatever, but none of them were really reusable. And that's kind of where I wanted it to focus, or like my alternative to focus. So I was in the ED trying to figure out various things that I might be able to use, whether it was like a little mini bag or something like that that I could kind of bring with me, and nothing was really working. And I was on shift talking to Dr. Slomer, who's a co-author to the paper, and he asked if I had considered the old school Defib-Pads. So where I trained, we only had the adhesive ones. I'd never used the old school ones, and we were miraculously able to find one package in the ED and started trying using it, and it just worked really well. And so then I got super excited. I went home, bought a package of 10 from a third party by myself, and then just started kind of messing around with it to see what I could do, what conditions I could subject it to that may be applicable to wilderness medicine. Did it actually work? What were the pearls, pitfalls, that type of thing. Got a co-resident to volunteer as my POCUS model, and just kind of took a bunch of clips and stills of the various probes, which we'll talk about in a second, and was pretty satisfied with that. And I was like, perfect, I have my kind of my solution here. Sent the images to my fellowship director at the time, because he was curious what I was doing. And he said, well, why don't we make this into a paper, and do more of like a proof of concept thing, see if other people kind of agree that the images are usable, all that type of stuff. And that would be my like fellowship research paper type of thing. So that's kind of how it got started. Moving into just the paper itself. So again, to summarize, it was just Didn't really love ultrasound gel in the Astir environments, just wet, bulky, finite, and makes it a bit impractical. So then I was looking at the intervention of being an alternative coupling medium, the Defib-Pads, and then comparing it to the conventional ultrasound gel, obviously. And then the outcome was just really looking at could the Defib-Pads generate images of adequate quality, and then would they actually perform in the conditions that made conventional gel just a bit annoying and undesirable? And that's where the survey came in. So the things that I subjected the pads to, or conditions, I guess, were other than the normal, just regular gel and the pads new out of the packaging. Threw a pad in the packaging in the freezer overnight, took it out, took very little time to thaw, and then used it after that. The next permutation was to open it, throw it in my garden for an hour, leave it, and then just wash it off in the sink and see if that worked. The other one was I just opened a package and left it on a towel on the kitchen counter for 4 hours to see if it drying out a bit would cause issues with it. It did. And then so with that, I was thinking, okay, can I actually re-moisten it to give it its properties back? Would that then I could kind of pull it back from the brink of being unusable to then something that I could actually use again. So that was the wet after air dry situation. The double thickness was just to try to put two probes or two pads together to see if I could increase the thickness in some of the situations where you want a bit more of coupling medium, like your low BMI patients or things like that. And then the probe cover wasn't actually for sterile procedures or anything from that standpoint. It was actually more of an idea to protect the probe from the elements that you might be using it in. So fine dust, dirt, sand, salt water, that type of thing. But it was still using it in the same type of way that you would use a sterile probe cover. So the lining on the inside between the probe and the cover, and then one on the actual patient. And again, wanted to see, okay, does this hold up across multiple different probe types? And so just tried to take a representative still image or clip using each of those ones. So the linear was the MSK ulnar nerve, curvilinear for your right upper quadrant kind of fast view, and then the phased array for your parasternal long. And again, I only did it on a single healthy volunteer, but that was kind of my own little experiment that I had created prior to the survey, which was our actual publication. So it was a descriptive cross-sectional survey. Everyone loves surveys of Canadian physicians that were already interested in, trained in POCUS, and so already kind of I had confidence, could interpret the images and actually answer the questions appropriately. And they were just given a series of these images or stills randomly assigned and assorted and just asked dichotomously, were the images of sufficient quality that you can interpret it? So can you tell there's a nerve there, a vessel there? Can you tell if there's free fluid within the hepatorenal space? Can you tell if there's pericardial effusion, that type of thing? And if they said no, I kind of asked to clarify what about the image was not interpretable. And so the image or the selection of images you see there are what are directly published in the paper there. And as you can see, E is the air dry modality and is absolutely horrendous. But all of the rest of them are reasonably interpretable for the most part. But the other thing, so it's hard to publish clips in papers and that type of thing. So I do have some of the data that this would have been part of the survey. I figured that you guys might be interested in seeing it as well. But so again, these are just the parasternal views. And the one on the left there is actually a conventional gel. The one on the right is a new defib pad. And then the one in the middle is the dirt rinsed image that was used. And similar, again, these are not the greatest quality right up views, which is partially why people were having, I think, some issues with the interpretability of the images in the question. I'll get into that in a second. But all reasonably kind of interpretable with the new Defib-Pad and the double thickness as just kind of examples there. We wanted to verify, as far as the results, just the respondent demographics and verify who we were actually getting responses from. Because when we had sent out the email to the listserv, we essentially said, if you have any colleagues that would be interested in doing this as well, like feel free to pass on the survey. So just wanted to double check and see what was going on there. But the vast majority were highly POCUS trained emergency physicians, mostly in academic centers, but we at least were able to get a little bit of a smattering of people from across the country, which was nice. But again, was kind of within that more niche academic POCUS population. But the stuff that we really cared about, obviously, was the whether people thought that the images were interpretable. And 80 to 100% of the time, roughly, the images were considered to be interpretable, which is quite fantastic, other than the air dry, which was 0% of the time. Again, not surprisingly. But with some of the respondents, some people said, okay, well, I can't see the full hepatorenal interface. I feel like I would have wanted to see the full sweep, and therefore I'm going to say that this is not interpretable to answer my question. So there was some kind of answers like that made me think, okay, well, you probably can actually see it, and it's just I gave you a poor quality clip that didn't give everything that you were looking for. And so I think had I been better about wording the questions or getting full scope of the clip there, then these numbers actually might be better than what we're seeing here. So just kind of moving on to the discussion, really short paper and everything, but the idea was just to do a proof of concept. Can these be used as a viable alternative to commercial gel in very specific situations? And I think the answer to that is yes, based on the results that we got. Again, I don't see this being replacing commercial, like regular gel in a regular ED. It's just not quite as nice to work with as the typical ultrasound gel. But it does have, I think, a couple advantages over some other gel alternatives that were already in the literature as well. So some stuff like hand sanitizer, maple syrup, shampoo, things like that other people have talked about. I just really don't love the idea of putting that on my own personal ultrasound probe. I don't know what it's going to do to the membrane over time. Is it actually going to break down, all that type of stuff? This being a medical grade kind of equipment already, I really liked the idea of having that as a base and not having to worry about the other things. It's obviously reusable compared to the other options. Again, maybe not the most sanitary as using it on myself and whatever, but I would put the ultrasound or the Defib-Pad just in a little Ziploc baggie, took the air out of it, and I could use it even like the next day or the day after, and it would still function just fine, even if I just ran it under a bit of water. So that was kind of reassuring to me. And then you just don't have to have the issue with making your own gel and then figuring out how to carry that around as well. And then it's also a limited resource as well. But so it does have some benefits there for sure. As we kind of already talked about, some limitations were a single volunteer for the model, sole sonographer, and then obviously didn't use any handheld devices for it. It was all just like a cart-based system for it. And then we talked a bit about the participants for the survey as well. The pads do run about $7 to $10 a pad, depending on kind of where you can buy them from a third-party source. They're not always available. So that is a limitation in and of itself to be able to use. I don't know what it's like in the States or various hospitals down here, but I know back in Canada, there aren't very many places that actually still use the Defib-Pads. Usually we've kind of transitioned over to the adhesive ones. So good luck finding them in the ED. And then I didn't actually test the disinfection of the pads. I'm not sure how well the integrity of the pad membrane itself would hold up to a disinfection process. It'd be interesting to look at, but just was not done in this case. So for this study itself, and just kind of, again, a bit more of a behind the scenes type of thing, and some things that I learned and kind of came across, part is the sourcing of the material. So if you are going to look at something that requires additional resources like the Defib-Pad or whatever, ideally try to find something that's easily obtainable, that it's not going to be from a single website somewhere that you're not sure about the sourcing for, or it's going to cost you an arm and a leg for. So that I didn't realize how difficult it would be to get a hold of these things initially right off the bat. I mean, it doesn't change things. I still would have done it the way I did, but it is something to consider. Um, and again, people hate surveys. I hate surveys. I'm sure you all hate surveys too, to an extent. But sometimes there's no way of getting around that. So what I would say is try to tailor whoever you're going to send your surveys to a population that you know is going to be like nichely interested in what you're doing already. So I think had I sent this out to the just general Canadian emergency medicine physicians listserv, I probably would have gotten far fewer responses than sending it to the emergency physicians like academic ultrasound listserv. Those people tend to be a lot more involved in research themselves and a lot more curious. And so when they see this come across their desk, they're going to be a lot more likely to actually click on that link and complete your survey. The other piece was in submitting it for publication. So we initially tried to publish it in just a general emergency medicine journal. And I think because this is a little bit nichey, not a lot of people really understand or have much exposure to wilderness medicine, so they don't understand why certain things are being done or how they're being done, that there was a lot of questions and comments that weren't really relevant to the study, like asking how we like why we would be bringing like a Zoll into the pre-hospital setting. Doesn't that like weigh a lot? And not understanding that I can just, the whole point was just to bring the pads and use it in a different context. And they were kind of a little bit hesitant to go forward with the publication. So then we moved over to Wilderness and Environmental Medicine, where it is published. But again, that's a wilderness medicine journal. And so they were much more understanding of the context and all of that, and asked a lot of really good follow-up questions, gave very useful feedback and all that type of stuff that actually made the process much smoother and made the paper better in the long term as well. So if you do have more of a niche thing, then sometimes it is better to find a journal that would support that, and you might get better feedback from that standpoint. I haven't done any follow-up study or anything to this, but I was able to be given the opportunity. I did a wilderness medicine wilderness ultrasound day as part of a wilderness medicine elective in Canada 2 years ago, where I just kind of got to organize everything. It was for residents only, but from various backgrounds, some who had a lot of POCUS, others who had never touched an ultrasound machine in their life, and got to kind of get a bunch of the handheld probes, got to make the glucomannan powder like homemade gel, have the Defib-Pads, have a bunch of other gel alternatives, and get them to actually try using all of the different things with all of the different probes outside in these little parachute things, or however they wanted to do it, and actually in a real life kind of situation without the injuries associated, obviously, just scanning themselves and whatnot. And it was really cool to see. I would say that it didn't perform quite as well as when I did it, but I think that was also partly due to some like lack of experience-based stuff. So not really understanding kind of how to maneuver the probe to get the appropriate image, and kind of blaming it on the probe and the gel and that type of thing. But for the most part, the people who had some proficiency in the past did end up quite liking the 3M pad. So anecdotally, it seemed to go quite well, which was reassuring and kind of nice to see. But that's kind of just the only next steps that I've had the opportunity to go through with this paper and this topic. But that's all I have for you, and happy to answer any questions if there are any.
Awesome. That's great. So I think that, we were kind of discussing this in the background about this paper. I think that was the kind of interesting concept of actually using these kind of the old school defibrillator pads, and kind of thinking about, could you actually take that and use something that we use currently, So have you guys tried using one of the adhesive pads to see if you can ultrasound over it? Because that's been a big discussion of like stopping CPR. Could you actually do something to make this more useful so you could, decrease the amount of time off the chest if you're doing CPR compressions?
Yeah, so the problem with the adhesive pads is so the pad itself and obviously the adhesion to the skin would be fine. You wouldn't have like as much probably issue with interference from like an air perspective. But you would still have that fine layer of air between the pad and the probe itself, which would you would not be able to kind of get the ultrasound waves to pass through that. So you would need some sort of coupling medium, I feel like, on top of the pad to be able to make that work. So whether it's gel or the Defib pad or whatnot from that standpoint. I haven't tried it, but just thinking of it from that standpoint, I would imagine that you'd have some problems with that. And then
Gotcha.
you couldn't replace it. So say depending on where your pad is, and then some of them come with those little like things on them to the
Measure the depth of
depth.
compressions and what.
Yes,
Yeah.
yes,
Yeah.
exactly. And so then you're trying to maneuver around that. And do you actually have the proper spot on the chest for that patient that's going to give you the optimal parasternal long view or whatever you're looking for? So I haven't tried it, but I can see it being a bit difficult.
Yeah, that was kind of the discussion in the background. We're like, this is a really interesting concept of being able to use something that we don't normally think about as being a coupling agent. And so could we use something that we use all the time, which we all struggle with, I think, getting the probe in there during CPR and chest compressions. So that's actually kind of a cool point. Now, when you did this, you talked about how you got to try this out in a wilderness medicine, session. And so you were using handhelds at that point.
Yeah.
Have you thought about comparing those, the images from a handheld and from a cart-based system to see if there's any difference, which would make it even more useful out in the field?
Yeah, so I mean I tried again and like both in that setting in the wilderness medicine elective, but then also just at home on myself and whatever comparing and like looking at the images from like a conventional gel to that. And it was the quality difference I would say was very similar. So it's one of those like your handheld devices aren't going to give you quite the same resolution as a cart-based system will, just inherent of its own limitations. But I didn't feel like the images were any worse off as far as quality compared to the conventional gel with the Defib-Pads personally. But
So I'll tell you that the cardiac images that you showed actually look really pretty much the same, whether you were using conventional gel versus the defibrillator pads. So that's actually really, I think you get a better view of it when you're not using the high frequency component. So I think it's probably looked, at least from the images you presented, a little more difficult on those linear high frequency probe pictures as opposed to the cardiac picture. But I guess if you're, in an austere environment, I would think that if you're doing a fast or checking someone's heart, that would be a useful tool.
yeah, and I mean the other thing is too is like I think we all get spoiled when you're used to the like really high end like ME8s or M9s or whatever. That's I mean like what we use back in London, and you get used to the quality of those images, and then you move back to either the handhelds that are again not as good, but then at the beginning of my residency, we were just using the like the sonocyte like edges, which were like not very great quality either. And they're kind of almost like similar in quality to your handhelds. And it's like, well, that was good enough for the ED at that point. So the handheld quality is probably fine to answer your questions. But that's going to be what you're using in those situations, even if it is like, even if you're talking like base camp or something like that that has a bit more infrastructure. It's not just a spot in the woods or something. They're still probably only going to have something that's similar to the edge, that's smaller, a bit more kind of indestructible, probably lower resolution and whatnot anyway. So I think as long as you can kind of answer those basic questions with it, then that's really all that matters there. But
Yeah, I think that's kind of a great point that we're so spoiled, I think, as time goes on, how our image quality gets better and better and better that It's interesting. You also pointed out on your survey. So I think that for a lot of our, fellows trying to complete a research project in a year, doing something with a survey is a very realistic kind of project as far as a bite-sized portion. So you mentioned that, you kind of had some lessons you've learned about creating surveys. Anything you could add on that? Or that you hadn't, did you kind of pilot the survey ahead of time? Or did you write up the questions and just send it out?
So no, I wrote up, I wrote up the questions and we have a great, um, research assistant who's like hired on by the department to help all of the residents with their research projects and that type of thing. So she helped out with the actual survey software and all of that type of stuff and making sure that all worked. But I did get all three of, I guess all four of the co-authors on the paper once I felt like it was finished on my end to be like, hey, can you go through and just like take the survey and just make sure there's no bugs in it, make sure that this makes sense, make sure that the wording here is okay. And then I had one of my co-fellow also go through it because he obviously wouldn't have had the same type of exposure to the material as the co-authors would have, and just do the same thing that way. So I did have a couple people kind of look through it and make sure that it seemed reasonable before sending it out en masse.
Awesome. Well, I think this is such a great paper. And again, this was nominated for a SAMI under Best Broad Scale Innovation, because I think it's something that, this was such a great way for you to kind of think of a great fellow project too, in the sense that like you had a question, how can I work around this? And so you found a creative solution to that and got a paper out of it. So
Mhm.
awesome work. And I don't think there's any questions in the chat right now, but thank you so much for coming on. And we really appreciate all the work that you do.
No problem. Thanks for having me.
All right. And so our next speaker is going to be Dr. Michelle Clinton. And I'm going to pull up your slides 1 second. So Dr. Michelle Clinton is an emergency ultrasound fellowship director and associate professor of emergency medicine at the Virginia Tech Carilion School of Medicine and Carilion Clinic. And fun fact about her, she likes hiking, trail running, skiing, biking, and outdoors exploring, and especially loves the Blue Ridge Mountains. So I'm going to let you take this over and I will share your screen. And just tell me when you want me to advance your slides. There we
Okay,
go.
perfect. Well, thank you so much for the introduction and for having me here to talk about this study. I'll give you guys a little bit of background. You can see there's a number of authors on this paper. This was a collaboration with the University of Maryland, and the primary author was a University of Maryland resident, and then our second author was their ultrasound fellow. We actually gathered the data for this study in 2022, so it was quite a while between that and it kind of coming to fruition as a paper. If you can go to the next slide, please, that'd be great. So I really can't take a lot of credit for this personally. I met Dr. Salerno through the ACEP teaching fellowship a number of years ago, and she reached out to me knowing that we have a really strong wilderness medicine fellowship here at Carilion, because her fellow at the time, Samantha King, wanted to do this tele-ultrasound in the wilderness education project. And I sent it over to my wilderness medicine folks, and they were really excited and thought that we could easily participate and gather data during the medical student elective that our section does every year. So really all the credit goes to Sam King, and our wilderness medicine fellow here at Carilion at the time was Carver Haines, and he did a lot of the legwork from our side, as well as Stephanie Lareau is also our wilderness medicine fellowship director, and she was instrumental in getting this done and taking it to publication. So thank you to all of them. I was involved, and hopefully I can answer most of the questions. But that just is a little overview for you as to kind of how this came to be. So my interest in this, beyond just really enjoying outdoor activities and ultrasound, and I love working with our wilderness medicine peeps, I was particularly interested because at the time I did not have a fellow that year, but my fellow who was going to be entering the fellowship the next year had expressed a lot of interest in wilderness medicine and was hoping and planning to go on a Nepal trip that our wilderness medicine folks do every year. So I kind of went into it just hoping I could learn something that could be beneficial for him and his fellowship. And just, it was a really fun collaborative project. So that was sort of how it came to be and where my interest in this originated. If you can go to the next slide, please. So just in terms of pearls and pitfalls, there were a lot of things that we ran into with this study, both on the positive and negative side that I just kind of wanted to hit on, that maybe would be helpful for some of the fellows on to hear about as they're working through some of the challenges that tend to come up when you're doing clinical research. So the collaboration was amazing. I can't speak more highly of trying to collaborate on projects and reach out to colleagues that you've met at conferences or courses or other medical get-togethers, just because it's really fun, to work with another department and kind of expand your medical community, your networking, and your friendships. So I was really glad that Dr. Salerno reached out to us on this project, and then that my wilderness medicine section was so enthusiastic about going ahead and working on it with her. It's also helpful sometimes to use student interest and enthusiasm in a topic to kind of help you recruit and get things done. And that was sort of the case with our wilderness medicine elective and the folks that I got to help me with that. So that was another benefit with collaboration. Kind of on the downside is it can be hard to actually complete tasks sometimes, when you're between two different institutions and you have a number of people involved, you need to make sure that there's some accountability and everybody's task is well defined. So I have to give all the credit for that to the fellows that were involved. I think Carver Haines and Sam King did a good job just keeping in touch, keeping things moving forward. And then again, Dr. Salerno is just extremely organized and was really helpful as kind of the overseeing faculty on this paper, but scheduling regular meetings and kind of having a checklist of who's responsible for what and what sort of output is expected at each given meeting was really helpful just to make sure we actually were able to complete this paper. So that was just kind of a few things I wanted to say about the collaborative situation in this project between the two institutions. Moving on to my next topic with the participant selection, we kind of had to use what the two medical schools had in place. At Maryland, they recruited first and second year students who were interested in EM or wilderness medicine, and they put on a wilderness medicine kind of workshop day where they did some scenarios, and then they also folded into that just those kind of wilderness medicine rescue scenarios, these two ultrasound stations where the students were instructed either in tele-ultrasound or real-time live instruction on the FAST exam or the knee exam. And so they got one tele-ultrasound station and one live instructor station. So we had MS1s and 2s at Maryland, but then at Carilion, our wilderness medicine elective is for 3s and 4s. And so those students were from different universities. They had a little bit different levels of exposure to ultrasound among them. Most of them were fairly naive in their ultrasound exposure. We do have a pretty strong longitudinal curriculum here at Carilion. So there were a couple of those students who had more exposure because they had been through that M1 and 2 Carilion curriculum and ultrasound. So that was just a little bit of a confounder, having students with different backgrounds. So I think something that, could be looked at to sort of smooth over in future study designs. Let's see, it was helpful though, using some of these kind of pre-planned medical student courses, because I was able to kind of garner the support of the faculty from this Appalachian Wilderness Medical Student elective that was going on. It's a 4-week elective they put on about an hour outside of Roanoke at this camp. And so the students were all there. They were doing this activity, and it just was a nice opportunity to get a little bit of data out of it and also teach them along the way. Okay, so then moving on to design and sort of some positives and negatives that we ran into there. Again, it was convenient just to kind of be able to use these pre-planned or pre-existing medical student events to get mass data collection. I've done that a number of times with some little educational studies over the years, and it's always a good way to take advantage of being able to gather data when you've got a group of learners together. So if you can fit that into the curriculum, as a fellow or somebody who has limited time or who's interested in med ed research, or I don't know if it's quite research or quality initiatives, then those are sort of good opportunities to just be efficient in gathering your data and get some useful information out of an educational situation. We also, I think another positive to the design was just keeping it very simple. As you read this study, you probably realized that the participants only saved 2 images. So the right upper quadrant fast image, and then for the MSK exam, it was knee. So it was just a suprapatellar quadriceps tendon view. So I think that really helped in being able to break down our data and do the statistical analysis. But again, it sort of had a downside because I think it limited the agreement between some of our reviewers to only have that very limited amount of data. So that was just something, you know, to kind of consider for next time or a future study. The other kind of negative thing with the design, as you looked at the results, you probably saw that the inter-rater reliability was moderate, which was okay for most of the different images and questions that we looked at, but it was not very good for the tele-mentored ultrasound fast image quality. So I think that something that could have helped with that is just different grader variability and experience in fast interpretation. It wasn't really defined for the graders prior to being asked to look at the images. You know, it wasn't really said that you have to see all of the things you'd want to see on a right upper quadrant view. So between the 2 raters, one might have thought just seeing that liver kidney interface was adequate, where the other might have been looking to actually see the inferior pole of the kidney, the tip of the liver, the diaphragm, and the whole package of everything we'd like to see on a right upper quadrant fast view. So that was something we could define a little bit better for a future study design, and maybe would have made our inner rater reliability a little bit better if we had been a little bit more detail oriented there. Let's see, we didn't collect any info on their prior ultrasound experience. That could have been just interesting and helpful to know, but I think we kind of already knew it was going to be a little bit of an inconsistency. So those were a couple of the design things that either went well or maybe could have been tweaked to improve the study or future studies that are similar. And then in terms of the publication, I mentioned that we collected this data in like 2022. It got published last June. I think this stalled for a number of reasons, you know, fellows moving on and not having access necessarily to all the data. I'm not sure exactly what happened on the Maryland end, and a lot of this was driven by them. But I have to give all the credit to Dr. Salerno and Dr. Haines here at Carilion, because they really kept the conversation going and would check in every few months. And eventually Dr. Lareau found us a willing journal, and we were able to kind of bring this together and get it published. So I think just persistence and teamwork was sort of what made that successful in the end. I think some of the things that came out of this, just as major takeaways, you know, further instruction would have been good. We were really trying to simulate like an actual wilderness emergency where you might have an untrained person with an injured patient who needs quick ultrasound instruction. So that's why we didn't do a lot of that. But there's a lot of different variations that could be tested. Could we go to the next slide, please? All right, so this is more for your entertainment. This is what AI came up with when I asked it to give me a visual depiction of pearls and pitfalls of ultrasound tele-ultrasound in the wilderness. So lots of potential things could go wrong. I think like the biggest technical things that we ran into that day were the really simple things of just Wi-Fi access at our facility being a little bit spotty. So of course that's going to be a challenge in the wilderness, but hopefully somebody's got some sort of satellite connection. And then just the technical issues with the probes and batteries. So we were using like first and second generation butterflies. So we had some issues with the probes overheating and then batteries dying on probes and phones. So I think just having lots of extra backup power sources, and then hopefully some of those probe overheating issues might be better with the newer generations. But I don't know, I've done a lot of teaching with the early generation butterfly transducers with really novice sonographers, people who are brand new to ultrasound. And it can be challenging just because that image quality is not always as good as what we would want. So those were really on the ground the biggest things that were problematic on the day that we gathered the images. Okay, can you go to the next slide, please? Okay, and this is just a few pictures from local on the left, and our wilderness medicine group does a trip to Nepal and a trek to Everest Base Camp every spring. So in terms of future ideas, there's so many applications for this. I think just locally and domestically in under-resourced areas. I know a lot of people within the emergency ultrasound section are doing some really cool things with longitudinal tele-ultrasound internationally with some fellows. I heard some cool talks at ACEP. So definitely tons of room to expand upon this. My hope was that we could do something a little bit more in depth with tele-ultrasound when my fellow went to Nepal in 2023. It was sort of just a scouting trip to see maybe with future Nepal trips, what can we do with ultrasound? Because of course that's a very under-resourced area where people just don't have good access to medical diagnostic imaging. So our wilderness medicine group, they did a big ultrasound workshop in Kathmandu at one of the medical school teaching hospitals. So they were able to expose a lot of learners just to some basics of POCUS that day. They did a couple of remote clinics as they trekked to base camp. And then this image on the bottom center is my fellow at the time giving one of our butterflies to the base camp ER. We just wanted to donate that to them because they were looking for a probe, and we had one that we could kind of spare. I wish we had had more opportunity to put more training in place so that, you know, it could be more longitudinal exposure to some of the docs there. But actually one of our former residents who trained with us at Carilion was working at base camp at that time and knows how to use ultrasound. So hopefully it got some use. So it hasn't really come to fruition in terms of future projects or studies, but I have a lot of ideas and hopes to continue this with future fellows and our wilderness medicine folks in Nepal, hopefully, or even just locally. So hopefully that was helpful. That's kind of what I had to go over for you guys, but I'm happy to answer any questions or discuss any other points that people wanted some clarification on. Oh, I think you're mute still.
Sorry, I'm gonna just stop share just because I have limited Wi-Fi. So just making sure I'm almost in an Astir environment here. So no, I think this is actually such a great study because it brings up so many different things that I think when you're putting together some medical education studies that I think really kind of speak to a lot of what it is that when you're trying to do a small study, and you brought this up beautifully, is that as a fellow, like you have a year. And so trying to get a project done in that time period, it may actually be a handoff from fellow to fellow to fellow in order to get something completed. And so I think that's something that was it really kind of is a common occurrence I think a lot of us actually face. Now, question for you. So when you guys were doing this, so they didn't have any experience, like you guys didn't give them like specific learning cues of like how to use the probe or anything like that, correct?
No, I think, you know, they had a live instructor. If they were in the tele group, they still had a live instructor there who was not supposed to put hands on them and really not supposed to instruct. They were just kind of helping to make sure they hit the right button to save the images. So yeah, no, they really didn't get anything beforehand. And most of them were at least familiar with it in our group. So, we would just give them a clinical vignette that you find this patient injured in the wilderness and they'd had some traumatic event. I don't remember exactly what it was. And we're just going to walk you through how to do this assessment for trauma. And then we went through the views with them.
That's pretty cool. I think that's actually such a great I mean, I think this really opens up so many things, like you said, for like things like Nepal and whatnot. I guess the question is like that, what you really hit on is one of the questions I had, which was the technology component of that. Is that depending on where you are in these environments, you may or may not have Wi-Fi capability or satellite or whatnot. So that does to make it a little bit more challenging. So I think that was an interesting. Does the base camp in Nepal have like good internet connection, or would that be something that you guys could do as a next step?
I need to look into that a little bit more. I think they do have some of it because they have like some satellite connection and stuff, but I'm sure it's expensive and not super reliable. So yeah, I need to look into that a little bit more.
That's just kind of an interesting thing you don't really think about. We always think about like, it's great using technology to teach from a distance, but how do you get that technology to places that need it most when they may not have the Wi-Fi capability? So I think that's, I don't know if satellite phones can do any type of kind of transmission, but that would be a cool
Yeah, maybe not.
question. And then let's see other questions I had. And so I think you actually brought up another point that, I think both papers kind of talked about the same thing is when you're teaching novice learners, we tend to look at QA, I think, as an expert in a way to say you're missing all of these things, but what is it that you really need for that diagnosis? And so it may not be the perfect image, but just really kind of bringing them to that point. And so I think that's something that, I always struggle with is like you think that people are going to look at the images and review the way you would look at them, but that doesn't always work. So did you guys have like a way that or anything that you gave them to say, these are the scenarios, this is what they were given so that maybe they would have a little more grace or with how they were grading it, or were you just
Well,
kind of let them through?
it was just two raters. There was one at Carilion. So one of our other ultrasound faculty who was not there the day that we gathered the images, and then somebody at Maryland. And so I think it was just because they were ultrasound faculty and are allegedly people who do a lot of QA, it was just sort of like use your regular criteria and then some of the ACEP criteria that's been established for QA, just the way we normally would rank image quality. So yeah, there wasn't a lot of specifics there, which I think is something that was pointed out in the manuscript. That's a way that we could kind of reduce some of the inter-rater variability in the future.
Gotcha. Yeah, I understand. I think that's sometimes, just being an expert in that, you have very specific, criteria you want to be shown. And I'm always a hard grader. The 1 to 5 scale, my interns or residents never get fives. And so they're always like, how can we get better? So great. And let's see if there's anything else. Is there anybody in the chat, or you can just kind of pipe up if you have any questions? And then one other question, if no one else has one, is so you had them do a fast and a knee ultrasound. Did you find that they were able to learn the fast? Was that easier for them? What were their thoughts? Did you talk to the medical students? Which one did they feel more confident with? Because I think that those are such very different skills. Like I think your fast is like so basic, and I feel like MSK is so hard.
Yeah.
But I think that for your scenarios, though, those are great ideas for being out in the wilderness.
Yeah. I mean, I think they struggled some with the fast just because, it's hard when I have a hard time personally not like putting my hands on the probe and just explaining verbally how I want my learner to manipulate it. Even when I'm at the bedside, like I just want to touch them, and that's maybe a me problem. But I think there's a lot of ultrasound educators who feel somewhat that way. So it was really challenging, especially, in those left upper quadrant views where there's so many nuances of where your probe location is and like the minor little rotations and getting your splenic diaphragmatic view. So I think they really struggled with that. I don't remember them struggling with the knee quite as much. And I was a little surprised that it wasn't higher between both groups in terms of the image quality being adequate for diagnosis and stuff. I wonder if anisotropy had a lot to do with that, because I think that's something, that would be really hard to correct as well as you would in person through a screen, because there's just such a little variation on that angle that you're looking at the tendon that's going to affect your view. But I think they liked the knee. I mean, it's always nice to start with the knee because it's just a big joint and it's not nearly as complicated as some of the others we look at. So I just remember the FAST being more frustrating for the students than the knee.
Gotcha. And then as far as when you guys were doing your corrections, like when you're virtually, I know it's so hard not to pick at the probe and just show them and demonstrate things. Could your kind of teachers be able to see what they were seeing in a way that they could say you're too high, you're too low, or anything like that? Or were they just looking at the images?
Yeah, no, we could see them. If you look in the paper, there's like a side-by-side image. So you had a video feed of the person scanning. So you could see their probe on the patient. And then you had your image through the butterfly tele ultrasound platform that you could see live. So that was really helpful just to be able to, tell them how to manipulate the probe. But again, like when you don't have time to prep your learners and you can't say, here's the universal language that we use, slide, rotate, tilt, whatever, it becomes a little harder. So that was a challenge. I found myself saying like, bring the cord end of the probe down towards the bed rather than like tilt to look anterior, because I just didn't have time to like establish these are my usual words for probe manipulation and we're all going to use this, So I guess in a real life scenario, that's how it's going to be. But in an educational scenario, it would have been nice just to kind of go through some of that at first before we did it.
Yeah, I think you brought it. That's a great point. And that's, if you're doing this in the real world where you're really walking people through this, then you're not going to have that language. But yeah, even with that language, sometimes you still just want to grab the probe from them.
Yeah,
It's hard trying to keep
it
your hands on.
is.
Well, that was awesome. Well, thank you so much for that. I think that both of these papers really kind of highlighted that, how we can use ultrasound and things that are not like the best environment, but still be able to get great images. And so I think that, this paper is so great in the sense that you really have opened up the ability to use this in so many other applications and prove a proof of concept, right? So that this does work. It may not give you perfect images, but I think some of us struggle with getting perfect images in our perfect environment. So there's that. I think that since there's no other questions in the chat, thank you again so much for coming. And I know that you were on shift, so I really, really, really appreciate you taking time out of your busy shift to come over and talk to us about this paper, because I think there's a lot of meat here that our fellows can really get things out of.
Well, thanks for having me, and I really appreciate it.